Good afternoon, everybody. This is Dr. Hart Beatty from the APDR. I'm chair of the Education Committee for the APDR, and we welcome you today for our second session for the APDR National Virtual Noon Conference. A couple housekeeping items that we went through last time as well. This is being recorded, and the webinar and all the questions and comments will be recorded on our end. And if you have questions during the talks, please use the question and answer tool that is available through the Zoom platform. And if there are recurrent questions and time at the end, we'd be happy to address those. Once again, I do want to mention that for residents and other learners that were not able to attend this live session, the talks will be recorded and hosted on the APDR YouTube channel. We ask that you give us about a week for that turnaround to get those posted. So without further ado, I understand that some of you just came on and may have missed the intro to that, but again, the webinar will be hosted on the APDR YouTube channel, and the webinar questions and comments are being recorded. And please use the Q&A tool for questions that you might have. I'd like to introduce two amazing educators in our field. Dr. Barile from the University of Massachusetts today is going to be speaking on cystic lung disease, and Dr. Hammer from the Brigham is going to be speaking on infections of the immunocompromised host. Again, we are so grateful for your time in this very odd era of education, and we're grateful for your dedication to resident education. So having said that, I am going to stop sharing my screen, and I'll ask Dr. Barile to take over.
Alrighty. And is everyone seeing this clearly?
Yep.
All right. So hello, everyone. My name is Maria Barile. I'm from UMass Memorial Medical Center, one of the chest attendings there. And today we're going to talk about cystic lung disease. Okay, so here's an outline of what we're going to cover in the next 25 minutes. We'll start talking about the definition of a cyst as defined by the Fleischner Society. We'll talk a little bit about mimics of pulmonary cysts in the lung. And then we'll really focus in on 4 of the main types of cystic lung disease that you're likely to come across in your career: LAM, LCH, LIP, and Birt-Hogg-Debye syndrome. And I really had to focus this talk just to keep it within the time constraints, but these are entities that will not only show up on the boards, but you'll see in your everyday life. And while we're going through each of these topics, what I really want you to focus on are these 4 points. These will help you narrow your differential. So I want you to think about the demographics of the patient, what age and what gender they are. Do they have any other past medical history that might be relevant? I want you to focus in on the morphology of the cyst, meaning are they round and regular in appearance, or are they irregular in appearance? And then I also want you to focus particularly on the distribution in the lung, meaning is it upper lung predominant process, or is it a basilar predominant process? Because that can really help you focus your differential. And then other associated findings, both in the lungs and in the upper abdomen, particularly the kidney. So we want to pay attention to see if there's any renal abnormalities associated with these entities. So let's start out talking about what exactly a pulmonary cyst is. So according to the Fleischner Society glossary of terms for thoracic imaging, a pulmonary cyst is defined as a round parenchymal lucency or low attenuating area with a well-defined interface with normal lung. It has a variable wall thickness, and it's usually fairly thin, usually less than 2 millimeters in thickness. And they generally will contain air, but occasionally they can have air fluid levels and have fluid or solid debris or material within it. So here we have a nice example of a nice simple pulmonary cyst. It has a very thin regular wall. It has a very discrete interface with the normal surrounding lung parenchyma, and it's gas filled. So this is what we're talking about today, these pulmonary cysts. There are several mimics that you may come across, and sometimes it'll be really obvious it's a cyst, and other times you might have to analyze the image a little bit more closely to determine whether you're dealing with cystic lung disease or something entirely different. So emphysema is one of those entities that can have a similar appearance. Here on the left panel, there are images of pulmonary cysts, and you can see that all of these cysts have a nice, well-defined perceptible wall. But when we look at this panel on the right in a patient that has emphysema, we do see these rounded lucencies scattered throughout the lung. But if we look closely at any individual lucency, we don't see a perceptible wall in any of these areas. So it's really just an area that is devoid of normal lung parenchyma. And I'm just pointing out a few of them right here. So one way you can tell the difference between emphysema and pulmonary cysts is just by looking for a definable, perceptible wall. The other thing, you can use other, abnormalities or distribution of the findings. For instance, if it's all in the upper lobes and you can also see some paraseptal emphysema, it's more likely to be emphysematous change than cystic lung disease. Okay, another mimic would be a cavitary nodule. So again, in the on the left panel, we have our simple pulmonary cyst with nice thin walls. And in the right panel, we have a cavitary nodule from a patient with metastatic colon cancer. And you can see in this nodule, there's central necrosis. So this used to be a solid nodule. Now there are multiple lucencies centrally. And more importantly, you can see the walls have variable thickness to them, and they're a little bit nodular in appearance. And so sometimes this can mimic a pulmonary cyst, particularly as the metastases start to resolve and the chemo is starting to work, the walls can become thinner. And so looking at prior studies to seeing if there were nodular walls, more in earlier studies can be helpful. Another mimic would be honeycombing. And here in the right-sided panel, we have a coned down image of the left lower lobe showing multiple or numerous stacked cysts. So one thing that you can notice is that these cysts are very regular in their distribution. So they're in the subpleural portion of the lung, and then they're stacked one on top of the other. And you'll also notice that the wall thickness is slightly thicker than our pulmonary cysts in this panel over here on the left. But what's most obvious in the setting of honeycombing is usually the other findings that you're going to find in the imaging study. For instance, the associated volume loss, the traction bronchiectasis, and the architectural distortion will help you distinguish honeycombing in the setting of fibrosis from cystic lung disease. So now we'll go through these four entities that we're going to focus on as our main differential. Lymphangioliomyomatosis, or LAM, Langerhans cell histiocytosis, or LCH, lymphocytic interstitial pneumonia, or LIP, and Birt-Hogg-Debye syndrome. And these are very commonly seen cystic lung disease in any academic practice. I did have to exclude some other diseases that have cystic components, particularly amyloidosis and light chain deposition disease and other parenchymal diseases with scattered cysts, just because of time constraints. So let's start with LAM. This is a very common entity that many of you have probably already come across. It's caused by an abnormal smooth muscle proliferation in the pulmonary interstitium. It can also proliferate along the lymphatics and the vessels. But when the proliferation occurs in the interstitium, it causes air trapping and cyst formation. And this entity almost exclusively occurs in women of childbearing age. So that's something to keep in mind. If you have a 30 or 40-something-year-old woman who comes in with cystic lung disease, LAM should be one of the first things you think about. It has two main forms, the sporadic form, which is what we most commonly see, and also a form associated with the tuberous sclerosis complex. And while there are two forms, they both have associated angiomyolipomas in the kidney. So we can't use that to distinguish between the two. But it is something that we can look for to help us point us in the direction of LAM. And oftentimes these patients will either present because of chronic dyspnea, or they will present because of some sort of complication from this disease. And the two most common complications are chylous effusions, which happens when this proliferation occurs around the lymphatics and cause lymphatic obstruction, or recurrent pneumothorax. So these are two reasons why the patients may come in, usually for a chest x-ray initially, and then you see this sort of reticular abnormality on chest x-ray and they end up with a CT showing diffuse cystic lung disease. So keep this in mind, and also keep in mind that While this example here shows really extensive cystic involvement of the lung, early in the disease process, it may be much less involved. And so you may start out with some scattered cysts. So let's talk about these cysts in lamb because that's very important. So we've talked a little bit about the demographics of the disease, and now we'll focus sort of on the imaging characteristics of these cysts. So in lamb, the cysts are pretty much uniformly thin-walled and regular in appearance. They're often rounded and they're of relatively similar size. They're not all exactly the same size, but it's a relatively homogeneous appearance. And in between the cysts, the lung parenchyma is normal. So if we look at the image here, we can see we have all of these relatively rounded cystic lesions. In this case, they're abutting each other and there isn't much normal lung parenchyma. If you look really closely, you can see a little bit of normal lung in here, but this is pretty extensive disease in this patient. And you'll notice that the cysts don't have any nodularity in the walls. The walls have the same thickness around. So it's a pretty monotonous, homogeneous appearance to this cystic lung disease. The other thing I wanted to point out is the distribution in the lung. So even if you look at the axial slice here, it's very homogeneously distributed. And when we look at our reconstructed images, either the coronal or the sagittal images, we can see the distribution is indeed diffuse both in the craniocaudal dimension. So meaning the upper lobes have just as much cystic lung disease as the lower lobes. And that's pretty typical for lambs. So that's one thing that you can kind of hang your hat on. The distribution of the cysts will be very uniform throughout both lungs. The other thing I'll point out is that the abnormality does involve the costophrenic sulci. And the only reason I bring this up specifically is because one of the other entities that we're going to talk about, LCH, is sort of characterized by this sparing of the costophrenic sulci. So when you have a cystic lung disease, take a look at the costophrenic sulci to see if they're involved. And if they are, and it's a very diffuse involvement of these cysts, LAM should be pretty high up on your differential. So this patient also had angiomyolipomas in the kidneys. Here you can see several different fat-containing lesions in the kidneys. They're very small, but they're real. And that's one of the reasons why looking at the kidneys in cystic lung disease can be extremely helpful because it can really help you narrow your differential. If you see these scattered cysts, even if it's not as extensive as it is in this patient, and they also have these fat-containing renal lesions, the chance that your patient's going to have LAM is very, very high. Here I have another example of a 45-year-old female with acute on chronic dyspnea. And this patient presented with a moderate to large left-sided pneumothorax. These patients sometimes or quite often will present with recurrent pneumothorax. And if we look closely, we can see there's a little bit of fluid layering that left hemithorax, and that was sampled and turned out to be chyle. So this is a chylous effusion, which you will commonly see in these patients with LAM. And if they're going to show you a question on the boards, they very well may show you a case like this where you have all of these very regular rounded cysts with thin walls, evenly distributed throughout the lungs, and what do you know, the patient also has a pneumothorax and a chylous effusion. So this is sort of your typical boards type of patient. So in summary, I just want to focus on these four aspects of the disease again. So the demographics of the patients in LAM are females much, much more commonly than males, and almost exclusively in women of childbearing age. The morphology of the cysts are smooth, rounded cysts with thin, very, very reproducible wall thickness. The distribution is diffuse, both in the axial and the cranial caudate dimension. It involves the costophrenic angles, so it's important to make note of that. And then associated findings that can also be extremely helpful in narrowing your differential are looking for any associated effusions. If you do see them, you can recommend that they tap them to evaluate for chylous effusions, associated pneumothorax or recurrent pneumothorax, and renal AML. So any fat-containing renal lesions will really help you narrow that differential. So moving on to pulmonary Langerhans cell histiocytosis, or LCH. This is a very common disease, particularly in the smoking population. So this is a smoking-related cystic lung disease. All of the patients with LCH will have a smoking history or a smoking exposure. And this entity is caused by proliferation of a dendritic cell of the monocyte macrophage lineage that resembles a cutaneous Langerhans cell, thereby the name. Patients generally present in the 3rd to 4th decade of life, and they usually present with, sort of these vague symptoms, again, dyspnea, cough, and fatigue. And if there is a pneumothorax, they'll present with chest pain. So recurrent pneumothorax is common in this entity also. To focus in on the imaging findings, LCH is an entity characterized by both nodules and cysts. So the nodules tend to be somewhat ill-defined. Like if we see these little nodular opacities in this example here, they're not really well defined nodules. They have sort of irregular borders, and they're kind of, not super distinct compared to the surrounding parenchyma. And eventually these nodules will become cystic, develop cystic spaces with them, and eventually turn into cysts. And the cysts are characterized by having bizarre shapes, meaning the shapes are very irregular. They're not necessarily all round or all oval. They're really can be highly variable in their contour and wall thickness. So that's something that you can sort of look for. And if you just sort of step back and take a look at this sort of cystic lung disease is very coarse in appearance, and that's because of the heterogeneity of the cysts that we're seeing. The other defining characteristic of LCH that we should always remember is that is an mid and upper lobe predominant process. So it's a smoking related disease. So these sorts of smoking related abnormalities tend to be most prominent in the upper lungs, and LCH is it also is seen in LCH. So we should always remember that. One last thing I wanted to mention is this is the entity where it does spare the costophrenic angles. So it's really important to look at the costophrenic sulci just to see if there is any involvement down there. And I'll have a few more examples showing that. Here's an example of very early in the course of LCH where we have some ill-defined nodules. So I'll point this one out here. You can see the borders are not very distinct. They kind of feather out into the surrounding lung parenchyma. We've got another nodule here and another one here. So here are these ill-defined nodules, and then we have another one here that has a central lucency in it. So this is very early stage LCH. This is the same patient, a sagittal view, and you can see all of these tiny little nodular opacities are kind of scattered throughout the lungs, but they're predominantly in the upper lobes and the superior segment of the lower lobes. And you can see there's relative sparing of the lower lungs here. The other thing that strikes me about this image is that there is this mosaic pattern of attenuation that we're seeing, and that's probably attributed to air trapping, which you will not always see in LCH, but you may see it. Here's another example of LCH, and I'm trying to give you several examples of this entity in particular because there is somewhat of a wide variety of imaging appearances that it can present with. This is another patient that has, again, all of these ill-defined nodules, but these nodules are a little bit bigger, a little bit more obvious, and some of them are developing this central lucency. So we're kind of looking for that, to see these ill-defined nodules that are developing central lucency, and these will eventually develop into these bizarre shaped cysts. And again, I just want to point out, if we look at the sagittal image, we can see that, again, it's the upper lobes and the superior segments of the lower lobes that are most prominently involved with, pretty marked sparing of the lower lobes. This is the same patient following steroids and smoking cessation. So this patient had a remarkable recovery, and there is a huge variability in recovery from this. But this patient, most of the nodules have resolved. You can see there are a few of these ill-defined nodules remaining, but we're left with all these little cystic spaces, and it's actually a little bit difficult to distinguish this from baseline emphysema, but we know compared to the prior study, there were nodules in these areas. And so this patient has recovered really well. These cysts won't go away, and the cysts do correlate with the pulmonary function abnormalities on PFTs. So this is something that the patient will have forever. Here's another patient with pretty striking disease. Again, you can see from this coronal, the striking mid and upper lobe predominance of the abnormality. And all of these cysts are very irregular in appearance. They have walls of variable thickness. If we look over at this axial image here, this is sort of a very irregularly shaped cyst right here, and then another one here. So this really is the defining characteristic of LCH, these bizarre shaped cysts. And then if you can see these associated nodular opacities, this is pretty much a slam dunk LCH, it even spares the costophrenic sulci, which you'll see pretty commonly in this entity. And then this is sort of at the end of the spectrum, the end stage disease, where all of the nodules have kind of become cystic. It's sort of burnt out disease, and you just are left with all of these sort of large, confluent, irregular cystic spaces scattered throughout both lungs. Some of the cysts have some wall thickening remaining, but it's more prominent in the upper lobes. The lower lobes and the lower lungs are involved, but to a much lesser degree. And so as this entity progresses, it starts in the upper lobes and then kind of, inches its way down into the lower lungs. So in summary for LCH, the demographics include smokers, and women and men are usually similarly affected. Different studies will show different things, but I think that has a lot to do with the gender predilections of the smokers in those particular populations. The morphology includes ill-defined nodules and irregular, bizarre-shaped cysts. And the cysts have variable wall thickness. And you can just tell it looks very coarse in appearance, and that's from that heterogeneity. And the distribution is also very important to remember. In LCH, unlike LAM, which was very diffuse, LCH is a mid and upper lung predominant process. And you could see that pretty clearly in this panel here. Other associated findings usually relate to other findings seen in smokers. So you'll see emphysema in the upper lobes. You potentially could see DIP with diffuse ground glass opacities, and DIP also has some cysts associated with it, or manifestations of RBILD with central lobular nodules in the upper lobes. Okay, so moving away from the smokers, we're going to talk a little bit about lymphocytic interstitial pneumonia, or LIP. This is very common in patients that have these connective tissue disorders or autoimmune disorders. And it's regarded as a variant of diffuse pulmonary lymphoid hyperplasia, which involves the interstitium of the lung. The risk of malignant transformation is fairly low. It's estimated to be about 5% or less. And previously, long time back, it was thought that this entity would progress to lymphoma, but we now have figured out that a lot of those patients that were inappropriately classified as LIP probably had lymphoma from the start. So very low chance of malignant transformation. And while some of these cases tend to be idiopathic, many of them have underlying systemic disorders. As I mentioned, the autoimmune diseases and connective tissue diseases. Sjogren's syndrome is one of the more commonly associated with LIP. But I also have seen LIP in the setting of lupus and in HIV, particularly in the pediatric population. So this entity tends to primarily affect women in their middle age years. So in their 50s is when they usually present. The symptoms are very vague. It's usually sort of similar to the other cystic lung diseases. Cough and dyspnea are usually the presenting symptoms. And what often happens is patients will have this diagnosis of Sjogren's, and they'll have a little bit of shortness of breath, and then they'll image them to see if there's any abnormalities in the lungs. But occasionally they will just be imaged for other reasons, and they might have subclinical Sjogren's or some sort of connective tissue disorder, and you can be very helpful in making the diagnosis. Okay, so let's focus on the imaging findings in LIP and how is this different from the other cystic lung diseases. So these cysts, similar to LAM, are very thin-walled and regular. They occasionally can have some septations like in this guy over here. The cysts are formed secondary to peribronchial cellular infiltration, and that infiltration causes air trapping and cyst formation. The cysts in LIP tend to either be sort of diffusely distributed or lower lobe predominant distribution. And one other thing I'll mention about LIP, at least in the cases that I've seen, the cysts are not as numerous as they are, or they tend to be in LAM or LCH. So there's more scattered cysts rather than a whole lung filled with cystic change. And there are other parenchymal abnormalities that you may or may not see in association with these cysts. They can be diffuse ground glass opacities or poorly defined central lobular nodules which may be ground glass in nature also. You can have septal thickening or thickening of the bronchovascular bundles. And in this case, we see sort of thin-walled cysts sort of scattered in the lower lungs. And we also see some bronchial wall thickening. This is the same patient. And you can see sort of this perivascular location of some of the cysts, and that's something that you can kind of hang your hat on to look for, again, another cyst here that's sort of located, sort of wedged in between two branching vessels. And then here you can see there's a little bit of diffuse ground glass opacity associated with these cysts. And just note that the cysts are not very numerous in this case. They're just kind of some scattered cysts, thin-walled, with some associated ground glass. And importantly, the cysts have this perivascular location. So this is a pretty good look for LIP. And this is a 40-year-old female with a history of lupus. So it all kind of fits together. This is a 52-year-old woman with Sjogren's syndrome and LIP, and another patient. And you can see, again, we have sort of a handful of scattered cysts in a lower lung predominant fashion here. And the cysts are really kind of wedged in between these vessels here. Sometimes when the cysts get larger in LIP, it can be a little bit difficult to determine whether they're really perivascular or not. You know, I tell the residents usually to look for the smaller cysts because that can be a clue. But here again, we have these sort of well-defined cysts. Most of them have a perivascular location and maybe a little bit of ground glass abnormality associated with it. This is another patient, a 48-year-old with Sjogren's and LIP. Again, just showing these very thin-walled cysts. Some of them have a perivascular location, some of them don't. But if you look at some of the smaller ones, you can kind of see the vessels adjacent to them. This one is more associated with the fissure. So not as straightforward as some of the other, but still there are enough findings here that where you can really raise the idea of LIP with some confidence, particularly if you know the patient has Sjogren's. And if not, I usually will give a differential. Here's another patient who has a history of rheumatoid arthritis, NSIP, and was found to have LIP and follicular bronchiolitis on biopsy from a wedge resection. You can't biopsy these percutaneously. They need larger amounts of tissue for this sort of thing. And so here we can see there is all of the cystic change running along the bronchovascular bundles and the vessels here. The cysts in this case are much smaller. So this was sort of that spectrum of LIP, follicular bronchiolitis. And then there is associated ground glass abnormality running along the bronchovascular bundles, which may actually be part of this NSIP type pattern also. And here we have diffuse, another patient, a younger patient with rheumatoid arthritis and LIP who has extensive ground glass abnormality and very well-defined cysts. Again, this is more diffusely distributed throughout both lungs, but you can see the cysts are very thin-walled, but many of them are perivascular in location. So in summary for LIP, the demographics include females much more commonly than males. It often will occur in the 5th decade of life. The morphology of the cysts include thin wall cysts, and the distribution is either diffuse or lower lobe predominant. They're often perivascular in location. And the associated findings, when I see cystic lung disease, I look into EPIC or your electronic medical record and see if they have any autoimmune diseases or connective tissue diseases, because that kind of, helps really to make the diagnosis. You can also look for associated findings of ground glass abnormalities, septal and bronchovascular bundle thickening. And on to our last syndrome here that I'm going to talk about today, Birt-Hogg-Debye syndrome. This is an autosomal dominant syndrome that involves multiple organs and is associated with the folliculin gene. It involves, so the triad includes facial papules, most commonly fibrofolliculomas, and I have an image of that here that I kind of grabbed off the internet, so you can see these sort of whitish papules that are very smooth in appearance, and they're located usually on the cheeks and the nose and forehead. And they often have renal tumors. And this is why making this diagnosis is important. It's not as common as some of the other entities I've just discussed, but it's important to make the diagnosis because they do need to have some sort of screening for their renal lesions, which are most commonly chromophobe, RCC, or oncocytomas. So they're usually solid and enhancing renal lesions. Here I have an image of an RCC in a kidney right here. So most of these lesions will have to be biopsied and they have to undergo surveillance because they are usually multifocal. And then the third component are the pulmonary cysts. So these cysts, there's one shown here, is a very thin-walled cyst. They predominantly are seen in the lower lungs, in the paramediastinal or subpleural location. They can be either rounded or oval, and sometimes the larger ones will have some septations. And these patients also can present with recurrent pneumothorax, due to cyst rupture. So if you have a patient who's had a couple of pneumothoraces, they might benefit them to get scanned. And if they have these cysts, we can kind of, look at the kidneys and sort of take a look at the whole picture. They can run a gene test for this syndrome to evaluate for that. Here's another patient I saw a couple years ago, 52-year-old male with a history of recurrent pneumothorax, and he was genetically proven to have Birt-Hogg-Dubé. And you can see there are these thin-walled cysts. Some of them are more oval, some of them are a little bit round. No nodules associated with the cysts, and they're more prominent in the lower lungs. Here's another case I saw a couple of years ago where we have these lower lung predominant cysts that have some septations. This is a larger one. You can see here on the sagittal image, there are a couple of septations here, and located in the subpleural and paramediastinal location. And while there are some cysts in the upper lungs, they're smaller and the upper lungs are not as affected. So in summary, for Birt-Hogg-Dubé, not the most common entity out there, but we can actually make an impact if we make the diagnosis. Demographics include patients presenting fairly early in life with, sort of vague symptoms, potentially recurrent pneumothorax. The morphology of the cysts include, again, thin-walled cysts, and they may have some septations in the larger cysts. The distribution being usually lower lung predominant, paramediastinal or subpleural in location. And the associated findings are renal tumors. So we really want to make sure that we look at the upper abdomen to screen for tumors, potentially have them, get an ultrasound or an abdominal CT to look for any kind of renal tumors. And they often will have skin findings at the time of presentation. So they'll have all these fibrofolliculomas on their face. And that can be helpful in narrowing the differential. So in summary, we spoke a little bit about the Fleischner definition of a pulmonary cyst and various mimics of pulmonary cysts in the lungs. I focused the discussion mainly on 4 common types: LAM, LCH, LIP, and Birt-Hogg-Dubé syndrome. And what I really want you to take away from this talk is how to narrow your differential. And to do that, we really need to not only focus on the imaging, including the morphology of the cysts and the distribution of the cysts in the lungs, but we also want to focus on the demographics of the patients, which we're going to have to, delve into the EPIC or the electronic medical record to get, and also any associated findings that we may see both in the lungs and in the upper abdomen. So I have a little chart that I made here. You can kind of take a screenshot of it for reference later. That just goes through sort of the main defining characteristics of each of these types of cystic lung disease. And I just wanted to say thank you to everyone. I've included my email here. If anyone has any questions about this presentation or any questions about our cardiothoracic imaging fellowship at UMass, please don't hesitate to send me an email. I'd be happy to talk with you. Thank you.
Thank you, Dr. Barile. We really, really appreciate it. It was a really wonderful talk. I'll have you stop sharing your screen. And Dr. Hammer, if you wouldn't mind starting your screen and sharing again, we will try to address any concerns you have through the question and answer tool. Please use that for communication. Thank you so much, and I'll take it away. Dr. Hammer, please.
Thanks. All right, and you can hear me and see my screen okay?
Yep.
Yep. Great.
All right, so I'm going to talk about pulmonary disease, mostly infections in the immunocompromised host. I will also touch a little bit on non-infectious causes that mimic infections. And so let me just, in the interest of time, kind of jump in. And the first important thing we need to think about when we're looking at scans of immunocompromised patients is we have to consider what kind of immunocompromise does the patient have, because that really determines what diseases and infections we're looking for. So there's 3 main categories of immunocompromise. One is T-cell depletion. Of course, the best example of that is HIV/AIDS, but there are other important examples that we see more and more now, particularly at the larger referral centers, and that would be patients who are solid organ or bone marrow transplant recipients, and patients who are on the so-called biologic agents for autoimmune disorders, particularly the anti-TNF alpha antibodies. The second important type of immunocompromise is neutropenia. And that we generally see in patients on chemotherapy, particularly the patients with hematologic malignancies who get very rigorous chemotherapy regimens. Also patients who are early like the early time period after bone marrow transplantation. Again, they haven't built up their neutrophils yet. And then finally, there's a category of non-specific immunocompromised, basically patients who are on steroids and other things like that, where kind of everything is depressed to some degree. So we'll go through these different entities and kind of focus on both the underlying immunocompromise as well as the imaging findings. Now, remember that in any immunocompromised patients, there are other non-infectious things that cause lung disease, obviously pulmonary edema, complications of their therapies, including radiation pneumonitis or drug toxicity. There are malignancies that we see in these patients, like Kaposi sarcoma and lymphomas. And then within the infections, of course, community-acquired pneumonias are very common, as well as the opportunistic infection. So we shouldn't forget about any of these entities when we're evaluating immunocompromised patients. All right, so let's start out talking about HIV-infected patients. And in these patients, it's important to know the CD4 count so you have an idea of what infections you're looking for. So patients with a CD4 count greater than 200 are thought to be relatively, more normal in terms of their immune system. And they're at most risk of developing just regular old bacterial pneumonias. They are also at increased risk of developing tuberculosis. Now, if your CD4 count is greater than 200, you get the sort of standard post-primary or what people call reactivation tuberculosis. Looks just like that in any other patient. And we'll go through more details on all of these entities in a little bit. If your CD4 count is less than 200, then you're at risk for developing Pneumocystis pneumonia, disseminated fungal infections, CMV, cytomegalovirus pneumonia, and then TB, and both the primary form and miliary form TB, as well as the reactivation TB. And then finally, if you're below 50, while you're at risk for all the things we just discussed, you are also at additional risk for developing disseminated non-tuberculous mycobacterial infection. Okay, so let's talk about TB. Obviously, that's a large topic, but in the setting of HIV, you'll mention a few specific points. So again, increased risk, particularly if your CD4 count is low. If it's below 200, then you're more likely to develop the primary TB or miliary TB form. So if you guys remember, primary tuberculosis presents as the most common, that's the form we most commonly see in children, and it presents with lobar consolidation in any lobe, as well as often lymphadenopathy. The post-primary TB, which is what we typically see in adult immunocompetent patients, is the upper lung predominant cavitary consolidation. All right. And then finally, miliary TB. What does miliary mean? It means that the tuberculosis organism has disseminated hematogenously throughout the body, and you may see it at any site within the body, including the abdomen, the bones, etc. The classic forms of miliary TB within the chest, of course, are the miliary nodules, like you're seeing in this particular case here, and lymphadenopathy, like what I'm showing you. Same patient here. This is the subparietal lymph node, and then diffuse tiny nodules that are essentially uniformly distributed throughout the lung parenchyma. All right. Don't forget that patients who are on TNF inhibitors, for example, for rheumatoid arthritis or inflammatory bowel disease, are at increased risk of developing reactivation TB. Typically, they will check these patients with PPDs before they put them on therapy, but we have seen several such patients who develop reactivation TB. Some more examples. This is a patient with primary TB. You can see this area, which almost looks like a mass of sort of a dense consolidation and necrotic lymphadenopathy. As another example of miliary tuberculosis, we see diffuse tiny nodules distributed nearly uniformly throughout the lung parenchyma. Some nodules are touching the pleural surfaces here. We've got a little bit of consolidation, which maybe reflects some airway spread, and then a lot of lymphadenopathy. You can see some of it on the lung windows here, and then here also this very large necrotic lymph node in the supraclavicular region in patient with miliary tuberculosis and HIV. HIV patients with very low CD4 counts are at risk of developing disseminated non-tuberculous mycobacterial infection. All right, so particularly Mycobacterium avium. So whereas in immunocompetent patients, you think about that Lady Windermere syndrome frequently, right, with the MAI infection. But if you're an HIV patient with AIDS and a very low CD4 count, under 50 or 70, then you can develop disseminated disease from this organism. And the main hallmark here is necrotic lymphadenopathy within the chest or abdomen. You may also see pulmonary involvement, like in this patient in the upper image here. And there is obviously overlap in the imaging findings between tuberculosis and non-tuberculous infections, and so cultures are required to make that diagnosis. All right, there's another important entity to remember in terms of HIV and TB, and that is IRIS, or immune reconstitution inflammatory syndrome. All right, and what that means is that if you have a patient with HIV, a CD4 count less than 200, who has tuberculosis, and they start the antiretroviral therapy, their tuberculosis can look worse. And why is that? That's because you get this dramatic inflammatory response. As your immune system ramps back up, it starts attacking the organism and it makes everything look worse. It's the same kind of phenomenon that we see in pseudoprogression on immunotherapy for cancers, right? So you may see, like in this patient in the bottom here, they had the supraclavicular lymph node that was necrotic. The patient was then put on therapy. This lymph node got much, much larger. And they did not change their therapy. They continued therapy, and they actually gave this patient steroids, and then this thing shrunk down. So the lymphadenopathy gets worse. Sometimes you can also see worsening pulmonary disease. The bottom line is, for therapy, they don't want to stop what they're doing thinking that it's wrong. What they're doing is actually right, and it's actually helping. And some patients may require steroids to help with the overwhelming inflammatory response. Okay. Moving on to other HIV-associated infections. I'm sure everyone's familiar with Pneumocystis pneumonia. It's an opportunistic fungal infection. Now, classically, we think about it in HIV/AIDS patients, particularly with CD4 count less than 200. But in the modern era, with better treatment of HIV and increasing organ transplants and other things, we see pneumocystis in a lot of other scenarios. In fact, in our practice at the Brigham, I would say that the majority of patients with pneumocystis are some type of transplant. So you can see this is a study from, I think, France, if I remember correctly, and it was kind of equal groups of HIV patients, solid organ transplant, hematologic malignancy, and autoimmune patients on corticosteroids. Now, generally, most of these patients are put on prophylaxis for pneumocystis. Sometimes patients are not on prophylaxis, particularly if they're on low steroid doses. And so that's a particular thing to look out for. And then sometimes you can still have breakthrough infection if the organism is resistant. Something to pay attention to in your electronic medical record, if you're looking at a patient and you think they might have pneumocystis, if they've sent off a beta-glucan from the blood, that's something to look for. It's typically very elevated in patients with pneumocystis. So if you have that lab result available, that can help you make your differential. Imaging findings of pneumocystis. The predominant imaging feature is diffuse ground glass. It's often quite extensive throughout the lungs, so it's not like one little ground glass nodule. I mean, it'll be sort of diffuse ground glass, but it may, this is very important, it may be very subtle. You can see in this first case, it was actually initially interpreted as just being mosaic attenuation. But you can see that the density here is really greater than normal for the lungs. And so this was true ground glass. Sometimes you can even use Hounsfield units to measure it. So this is a patient with pneumocystis pneumonia. These other cases are obviously, more apparent. I would say a little bit later on in the course of the disease, you tend to develop septal thickening associated with the ground glass. So you get that crazy paving pattern. And very late in the disease, you may see cysts or nematoceles. I would say that's very uncommon in the modern era, given our better therapies that we have for both PCP and for HIV. Very rarely you can get a nodular form of PCP, but that's extremely rare. So really what you want to focus on is diffuse ground glass. All right, so just to briefly touch on non-infectious things that we'll see in HIV that can sometimes simulate infections, would be Kaposi sarcoma. So the classic appearance is this sort of nodular soft tissue extending along the bronchovascular bundles. You may see sort of discrete nodules more distally in the lung parenchyma. This bottom case here illustrates that a little bit better, where you've got kind of nodular or consolidated foci, as well as these more confluent areas of soft tissue along the bronchovascular bundles. Frequently, you'll see some ground glass around these regions. Maybe you can see a little bit here that there's ground glass surrounding the nodules and consolidations. That ground glass represents hemorrhage in this sort of angiocentric malignancy. And so, you know, sometimes you could imagine someone might wonder, would this be a fungal pneumonia because they have nodules and ground glass halos? But in this case, it was actually Kaposi sarcoma. All right, so moving on to our other, one of our other main T-cell depleted categories, that would be patients with solid organ transplants. And a lot of the things are going to be the same as what we discussed. These patients tend to be a little bit less at risk of TB just because of their demographics, but certainly they are still at risk for TB. Don't forget community-acquired pneumonia. Organ transplant patients are at high risk of developing fungal pneumonias, including aspergillus and other things. This is an example of a patient with cryptococcal pneumonia, which tends to have sort of nodules often in the subpleural regions. We'll talk a little bit more about the invasive fungal infections a bit later with the neutropenia. Again, pneumocystis pneumonia, CMV pneumonia as well. Here is an example of mycobacterial infection in an organ transplant patient. So similar to other mycobacterial infections, we see some tree and bud nodules here, as well as a cavitary focus of consolidation. Again, the imaging findings are going to be not as typical as those you see, for example, in the immunocompetent patient, but anytime you see tree and bud nodules, you want to think about mycobacterial infections. And then we also can think about nocardia. We usually can't really make the diagnosis of nocardia prospectively based on chest imaging because it looked like a pneumonia. Here you can see a patient with several areas of consolidation. Now, the one time when you can want to think about nocardia is if the clinical team tells you that the patient has a brain abscess as well as lung findings, because that's pretty classic for nocardia to involve both the brain and lungs. But otherwise, there's nothing terribly specific about the lung findings in nocardia, and they'll have to do some kind of bronch or tissue sampling biopsy of some sort to make the diagnosis. Again, we don't want to forget non-infectious causes. So here's a patient with organ transplant who developed post-transplant lymphoproliferative disorder. And this is basically a lymphoma that developed caused by Epstein-Barr virus infection. These patients are immunocompromised and the infection cannot be controlled, and it causes this abnormal proliferation of lymphocytes. The main findings here would be lymphadenopathy. So again, you know, if you're thinking about your disseminated mycobacterial infections, you might also want to think about PTLD in the appropriate setting. But it can also cause some lung nodules. Here we see some nodules with maybe even a little bit of ground glass around them. So you might wonder, is this a patient with a disseminated fungal infection? But it turned out to be PTLD. So a lot of times these patients end up requiring a lung biopsy to make the diagnosis if they don't have other manifestations. Briefly, I will touch on lung transplant recipients, some non-infectious complications that you might see. So ground glass in the early post-transplant phase, you can see what's called primary graft dysfunction or edema. And then later on, we see can see rejection and pneumonias. So this is a case of CMV pneumonia. So viral pneumonia is one of the main causes, imaging features of viral pneumonias are ground glass. You can see this patient actually in their native lung developed ground glass throughout the lung. So remember we talked about ground glass with pneumocystis, and the other thing you really want to think about with if you have a ground glass pattern in a patient with T-cell deficiency would be viral pneumonias, particularly CMV pneumonia. Okay, and then here's another example of PTLD presenting as a nodule, again, which can simulate a fungal pneumonia. Okay, so neutropenic patients, this is the other important category of immunocompromise. And the duration of and severity of the neutropenia directly correlates with risk of infection, particularly risk of fungal infection. That's why we really think about fungal infections in the hematologic malignancies, because those patients tend to get the strongest chemotherapeutic regimens. and they're at particular risk of fungal infections. Of course, we don't want to forget other things like bacteria and viruses. So here are some examples of viral pneumonias. We see these pretty commonly in all sorts of patients. As I mentioned, ground glass is often a big feature of viral pneumonias. In some viral, so there's a huge overlap between different viruses. And obviously there's been a lot of discussion of viral pneumonias in the media, which we don't get into right now. But you know, viral pneumonias can give you central lobular nodules, like we see in this case. This happens to be a case of RSV pneumonia. Tree and bud nodules similarly. You can see ground glass. So as I mentioned, CMV pneumonia in particular tends to give relatively extensive ground glass opacities. So that's something you want to think about. But other viral pneumonias can also give extensive ground glass. And rarely you can get consolidations in viral pneumonias. It's definitely not by any means unheard of. So it doesn't exclude viral pneumonias if you see consolidation. But as I mentioned, it's just very nonspecific and we can't really make specific diagnoses based on imaging. Okay, so now the important thing that we all want to talk about is invasive fungal pneumonias. So particularly in neutropenic patients, you want to consider fungal pneumonias if you see nodules or consolidations with ground glass halos. So this is a nice example here in the right lower lobe. We've got a nodule with a pretty extensive surrounding ground glass opacity. So that's really the thing you want to burn into your mind. If you see this appearance in the appropriate patient, you want to think about invasive fungal pneumonias, the most common of which is Aspergillus infection. Sometimes you can see that these fungal pneumonias cavitate. It's, I would say, the minority of cases, particularly minority of neutropenic patients, but in more immunocompetent patients, cavitation is a little bit more common. And you can see one interesting imaging feature is the air crescent sign. So we see this patient here who was neutropenic, did this large consolidation with some ground glass, a sort of additional foci here in the left lung and the right middle lobe. Now, as the patient starts healing, and particularly as their neutrophil count starts coming back, their body starts attacking this infection better, and you get this little air crescent here, this sort of circle here as the, basically what's happening is the necrotic tissue starts contracting and you get a little bit of cavitation, but it tends to give this little sort of characteristic crescent shape of air. So if you see this, the patient's already getting better, which is the good news, but you can be a little bit more confident that this was probably an Aspergillus pneumonia. One thing I want to mention, we mentioned the beta-glucan with Pneumocystis pneumonia. It's another feature of fungal pneumonias, particularly Aspergillus and Candida, and is not seen with mucor infections. The elevations of beta-glucan tend to be a lot milder in patients with Aspergillus infection compared to Pneumocystis, where they're usually in the several hundreds, where we're talking about like tens to 100. If you're seeing it with Aspergillus. There's also serum Aspergillus galactomannan, which you often see. The sensitivity of that one is pretty low, so don't be dissuaded if this is negative. All right, so other fungal infections. I do want to mention Candida, which tends to more commonly give you a bunch of well-defined nodules without ground glass halos within both lungs. It's a hematogenously disseminated process, and you'll often see tiny microabscesses in the liver and spleen, like in this patient. So if you see splenic lesions as well as a bunch of lung nodules, Candida, again, in the appropriate setting, Candida is one thing you really should think about. All right, now moving on to mucor. The reason I mentioned mucor is that while it is uncommon, it's something very important to recognize because these patients require more stronger antifungal therapy, and it's a much, much higher mortality. And so it's something that the clinical team needs both for treatment and prognosis. So while mucor can appear identical to Aspergillus, it can give you nodules with ground glass halos. One thing that's a little bit more unique to mucor is the reverse halo sign, which is an area of ground glass surrounded by denser consolidation, like we see here. And this represents necrotizing infarction of this lung parenchyma. So all of these angioinvasive fungal infections destroy the blood vessels in the lung, and that's why you get some hemorrhage or ground glass around the nodules. But mucor is even more aggressive, and it destroys the vessels to such an extent that you just basically totally infarcted this part of the lung. So if you see this reverse halo sign, it doesn't guarantee that this patient has mucor. In a paper we did, we found that there was actually relatively similar numbers of aspergillus and mucor cases in patients with reverse halo signs. However, you really want to bring up the possibilities so that the clinical team can treat the patients more aggressively, and they may be inclined to biopsy them earlier to prove what the infection is. Mucor can also invade through the chest wall or into the mediastinum. Here's an example of mucor that's cavitated. Here's an example of chest wall and mediastinal invasion. And remember, in these patients, the serum beta-glucan is going to be negative because mucor does not have that component in its cell wall. Okay, so since I touched on the reverse halo sign, I just want to remind you guys that it can be seen in other entities. And here are some examples of reverse halo signs in patients with organizing pneumonia. Now, the big topic is COVID-19. We commonly are seeing reverse halo signs in that. And also, don't forget pulmonary infarcts. All of these, particularly these cancer patients, are at increased risk of developing pulmonary infarcts. And so that's something you want to consider if you see peripheral reverse halo signs. Okay, so patients with bone marrow transplant, I'm just going to go through these pretty quickly. There are some non-infectious processes, so-called idiopathic pneumonia syndrome, which is basically an ARDS picture that they get early after transplant. They're also at increased risk of developing organizing pneumonia from their drug therapy and from chronic graft versus host disease. So as you can see, there's lots of different entities, and the imaging features can sometimes overlap, but we can usually provide a relatively short differential for a lot of these cases. So to summarize, I just want to touch on the important points that we made here so you can give a good differential diagnosis. So don't forget, in immunocompromised patients, that you want to think about your non-infectious causes like organizing pneumonia from drug therapy, just as an example, or malignancy like PTLD. Bacterial pneumonia is still one of the most common causes of infections in these patients. So don't automatically say, oh, this has to be an atypical or opportunistic infection because the patient is immunocompromised. Remember that the type of immunocompromise is critical. So patients with T-cell deficiencies, particularly HIV or organ transplant, you want to think about mycobacterial infections, particularly tuberculosis, as well as pneumocystis pneumonia. Patients who are neutropenic, so really you want to think these are the patients who are getting chemotherapy typically. You want to think about fungal pneumonias, particularly when you see the nodules with ground glass halo. And then, as we said, specific imaging findings. If you see ground glass, all right, you're going to want to think about pneumocystis and viral pneumonia. So those are the key. Of course, pulmonary edema and other non-infectious things like alveolar hemorrhage can also give you the diffuse ground glass. So don't forget the non-infectious causes. All right, if you got central lobular nodules or tree and bud nodules, you want to think about viral pneumonias and mycobacterial infections. If you've got the large nodules, you want to think about fungal pneumonia and PTLD, particularly if you've got the large nodules with ground glass halos. That's the key for fungal pneumonia. But don't forget, we don't want to suggest fungal pneumonia in patients who are not immunocompromised because that's uncommon. It can happen, but it's not common. So you want to just make sure you're remembering the context. And then finally, if you've got a cavitary nodule, you want to think about fungi, mycobacterial infections, and then also nocardiac and cavitated. Okay, I know that was kind of a whirlwind, but let me stop there, and hopefully that'll give some time for questions at the very end.
Thank you so much, Mark. Yeah, we're reaching sort of the end of the session here. I do have a question here. Can PTLD simulate Kaposi sarcoma is one of the questions that was asked during your talk.
That's a great question. I suppose it can. I've mostly seen it present with nodules rather than these confluent peribronchial vascular soft tissue. But there's definitely a spectrum of Kaposi's, and some cases of Kaposi's look more like the discrete nodules. And in that case, absolutely, they can look very similar.
Okay, great. So we have reached the 1 hour point. I want to again thank Dr. Barile and Dr. Hammer so much for your time for this. I would like to let everybody know that on Tuesday we'll be holding our next session. We will be featuring Dr. Emily Webb from UCSF and Dr. Elliot Fishman from Johns Hopkins. and we'll start a day of abdominal imaging on Tuesday. So again, thank you so much, everybody. Be well, and we'll see you virtually soon. Thank you.